Hello, this is Juan Pablo Moreno-Ortiz. I am a second year internal medicine resident at the University of Arizona main campus, and it is with great pleasure that I present this very interesting case to you. Mystery diagnosis. It's compressing the spinal cord, but what is it? A 55-year-old male with a past medical history of asthma presented to our emergency department following a ground level fall. He was complaining of numbness and tingling at his fingertips that began 2 months ago. Bilateral upper extremity weakness and muscle soreness, however, began 2 to 3 weeks ago and has involved his lower extremities bilaterally, leading to recurrent falls. He is denying any loss of consciousness, lightheadedness, or head trauma, and other review of systems was negative. Significant findings on physical exam included bilateral wheezing on auscultation, tenderness to palpation of the cervicothoracic spine, right forearm, and hand. Neurological exam was significant for decreased sensation to the light touch of left V2 and V3, cranial nerve 5 distribution on the left side. Bilateral upper extremities were noted to have some motor deficits, 4 out of 5, and loss of deep tendon reflexes. Lower extremities bilaterally were otherwise non-remarkable, with the exception of some 4 out of 5 strength at the left hip. On the emergency department, the patient was noted to have remarkable hypertension, 172 over 126, some thrombocytosis, and imaging of his head and CT spine was non-revealing. However, an intramural hematoma of the thoracic aorta was found and mediastinal lymph nodes, for which CTA was recommended, and an S-model drip was started for blood pressure control. CT angiogram of the chest, abdomen, pelvis further characterized these aortic findings, not necessarily as a hematoma, for which the S-model drip was then discontinued, but as an aortic root thickening, aortic wall thickening, involving the aortic root, aortic arch, and this is what we see in this image, that beautiful thickening of the aorta, that was also noted to involve the right and left pulmonary arteries and renal arteries. Prevertebral soft tissue fullness of the thoracic region was noted, and multiple solid liver lesions were also seen. MRI of the spine didn't reveal any abnormal cord signaling or infarction, but it did reveal some very interesting findings. And what you can see here is some linear enhancement around the epidural space that was described as a probable large C3 to T6 circumferential spinal epidural hematoma, resulting in cord deformation. Differential diagnosis at this point involves possible prevertebral phlegmon. This is an infectious etiology. And if you lived in Arizona, you realize that coccidioidomycosis can look like anything. However, an inflammatory process could also be going on here. Vasculitis, an aortitis, a giant cell arteritis, an IgG4 related disease or sarcoidosis. Malignancy, however, was not out of the question. Infectious workup was soon negative. Blood cultures were not revealing cocci, syphilis, quantiferin, and HIV. Nothing was significant. However, an inflammatory workup did note an elevated ESR and CRP. An ANA was negative, but the P-ANCA was noted to be positive with an interesting titer. An IgG4 serum level was within the normal ranges. And at this moment, we haven't forgotten that the spinal cord has been compressed and it's symptomatic, for which cervical and thoracic laminectomies were performed. And despite our imaging findings that were thinking of this as a hematoma, no hematoma was seen in the OR. No infectious fluid collection was observed. The neurosurgeons conducted a pachymeningeal exploration in which a pathologic dural thickening concerning for leptomeningeal carcinomatosis was described. And at this point, our differential diagnosis moves malignancy to the high top end. At this moment, we are calling our pathology colleagues and asking for any preliminary results. And to our surprise, they're not finding much. They are telling us that they are still running some staining and to stand by. However, so far, no evidence of carcinoma, lymphoma, infectious, or vasculitic process has been found. At this moment, as serum and urine protein electrophoresis have been negative, and we want to obtain a cerebrospinal fluid sample. However, given the involvement of the spinal cord, we contacted our interventional radiologist who found that the best space for a spinal fluid sample was right at the foramen magnum, in between the occiput and C1. And you can see an image right there of that procedure. Unfortunately, however, other than some lymphocytic CSF, nothing was significant. Leukemia lymphoma panel was also negative. And we're scratching our heads, and we're getting ready to get perhaps a lymph node biopsy or something. And just at that moment, our pathology friends call us and tell us, we have a diagnosis. Further staining of the tissue, biopsy of the dura mater, did note some non-granulomatous lymphoplasmacytic infiltration with IgG4 plasma cell predominance, focal storiform fibrosis, and alliterative phlebitis. All of this providing enough evidence for the diagnosis of IgG4-related disease, manifested by aortitis, hypertrophic pachymeningitis. The patient was started on prednisone and noted significant improvement as to his muscle stiffness and pain within the next day. So let's talk about this. IgG4-related disease is a polyclonal fibroinflammatory disorder characterized by lymphoplasmacytic tissue infiltration with IgG4-positive plasma cell predominance. It is known to involve virtually every organ system. However, most commonly involves the pancreas, bile duct, salivary, and lacrimal glands. Involvement of the spinal cord is rare. It was first reported in 2009, and between that time and an October 2019 literature review, only 12 cases had been reported. Commonly presenting with signs and symptoms of spinal cord compression, numbness, muscle weakness, and imaging is often mistaken for malignancy or a hematoma, just like in our patient's case. Diagnosis often involves both clinical and pathologic findings, as biopsy is often necessary. Serum IgG4 levels have been noted to be normal in 40 to 80% of the patients with IgG4-related hypertrophic pachymeningitis. And here we have some of the classic findings of IgG4-related disease found in our patient's dura mater, some lymphoplasmacytic infiltration noted, and some storiform fibrosis. On the middle, we have some obliterative phlebitis of medium-sized vessels, and on the right, some immunohistochemical staining for plasma cells, noting some plasmacytic predominance of this tissue. Treatment often involves urgent surgical evaluation for the decompression of the spinal cord, as this could lead to permanent damage. Immunosuppression often involves steroid use, although the optimal steroid dosage is unknown. Other reported immunosuppressants have included rituximab, azathioprine, mycophenolate, cyclophosphamide, and cytarabine. These are my references. Thank you so much for your attention.